Cultural and socioeconomic dimensions of time-restricted eating, beyond biology. The biological framing of time-restricted eating research often obscures critical social determinants of both implementation feasibility and outcome sustainability. Cultural food practices, work schedules, economic constraints, and family structures all shape eating patterns in ways that interact profoundly with temporal restriction interventions. The failure to adequately address these dimensions in time-restricted eating discourse reflects broader limitations in nutrition science, where biological reductionism frequently overshadows social context, despite the latter's outsized influence on dietary behavior and health outcomes. Cultural food traditions center heavily on communal eating at specific times, often evening hours when families gather after work and school. Many cultural and religious practices involve shared meals that carry deep social significance beyond nutrition. Breaking bread together strengthens relationships, transmits cultural values, and provides essential social connection. Time-restricted eating protocols that preclude evening eating directly conflict with these practices, creating forced choices between health interventions and cultural identity maintenance. For immigrant populations or cultural minorities already navigating acculturation stress, dietary interventions that dismiss traditional eating patterns may prove particularly alienating. Religious fasting practices add complexity. Islam's Ramadan, Christianity's Lent, Judaism's Yom Kippur, and other traditions incorporate fasting, but within specific spiritual frameworks that differ markedly from health-focused time restriction. The appropriation of fasting language without spiritual context may feel disrespectful to some religious communities, while others might find synergy between religious and health-motivated fasting. Healthcare providers must navigate these intersections sensitively, recognizing that religious fasting serves purposes beyond metabolic optimization and occurs within comprehensive spiritual frameworks that guide implementation. Socioeconomic factors profoundly affect time-restricted eating feasibility in ways rarely acknowledged. Shift workers, concentrated among lower-income populations, face scheduling constraints discussed elsewhere. Additionally, food insecurity, the unreliable access to adequate food, affects time restriction considerations fundamentally. For individuals uncertain about meal availability, voluntary meal timing restriction represents an implausible luxury. The assumption that people possess sufficient food to deliberately restrict eating times betrays class privilege that renders much time-restricted eating advice irrelevant to food-insecure populations. Work schedules and occupational demands vary dramatically by socioeconomic status. Professional workers often enjoy scheduling flexibility that allows eating pattern manipulation, while hourly workers face rigid break schedules, unpredictable shift timing, and limited break time. Service workers and laborers performing physically demanding work may require frequent eating to maintain energy and safety. Time-restricted eating protocols designed around white-collar schedules translate poorly to these occupational realities, creating yet another health intervention accessible primarily to privileged populations. Family caregiving responsibilities, disproportionately carried by women and varying by cultural context, affect meal timing flexibility. Parents coordinating children's meal schedules, adults caring for elderly relatives with specific meal timing needs, and individuals managing household food preparation must navigate multiple competing scheduling demands. Time restriction that benefits one family member may create logistical chaos or nutritional compromise for others. The individualized framing of time-restricted eating ignores the household-level coordination required for dietary implementation in family contexts. The research implications prove significant. Trial recruitment from homogeneous populations, typically educated, financially stable volunteers, limits generalizability to diverse populations facing different constraints. The exclusion of shift workers, food-insecure individuals, and those with complex family responsibilities from research creates evidence bases that don't represent whole populations yet inform universal recommendations. Intervention designs must incorporate cultural adaptation frameworks that recognize diverse food cultures and timing traditions rather than imposing culturally hegemonic patterns. Translation and communication present additional challenges. Nutrition messaging, including time-restricted eating recommendations, typically reaches populations through channels, healthcare systems, wellness programs, social media, with varying accessibility across socioeconomic strata. The framing often assumes baseline nutrition knowledge, cooking skills, and food access that may not exist universally. Effective health equity demands that dietary interventions either prove accessible across social positions or be explicitly framed as context-dependent rather than universal best practices. The takeaway emphasizes humility and contextualization. Time-restricted eating may offer benefits for some individuals in specific circumstances, but these benefits emerge within social contexts that enable or constrain implementation. Universal recommendations ignore social determinants at the peril of widening health inequities. Healthcare providers must assess social context, work schedules, cultural practices, food security, family structure, before suggesting time restriction. Research must actively recruit diverse populations and report stratified outcomes, acknowledging that intervention effects likely vary by social position. The goal extends beyond determining whether time-restricted eating works to understanding for whom it works, under what circumstances, and how social barriers might be addressed to broaden accessibility without cultural imperialism.